Those people who are living longer and living better will live to develop aortic stenosis.
Aortic stenosis is it's a narrowing of the valve between the left ventricle and the aorta, and that's the major outlet for the heart. And when you're born, that pressure drop across the valve is 0, and as you get older, it might get a little bit up, maybe 1 or 2 millimeters of mercury. When people have severe narrowing of the valve, the pressure gradient may be 40 or 50 millimeters of mercury. So what that means is that if your blood pressure in your arm is 120, the blood pressure in the ventricle might be 170, 180, 200. It's like having high blood pressure inside the heart. The heart has to work harder to generate the same output.
When I talk to patients, they want to be able to do the things that they were once able to and are now stopped by fatigue or shortness of breath, or in some cases even chest discomfort.
The age of the patients we're seeing with this, it's called senile calcific or degenerative calcific aortic stenosis, is 75 to 90.
So it's often someone who's had bypass surgery in the past, who may have a very calcified aorta that can't be cross-clamped, someone who's had a history of a stroke or a high risk for other kinds of risk. So we have to put it all together, literally, and come up with the profile for that individual patient.
Transcatheter aortic valve replacement is a technology that does not use the heart-lung machine. It's a technology where we use catheters, just as a cardiologist may use a catheter in the groin or in the arm to open up a coronary artery with a stent. It is the same basic technology, only we're using a balloon and a stent with a valve.
The aorta sits in an annulus, and it's a ring, and it's usually calcified. So as the valve becomes calcified, the annulus becomes calcified. So it's kind of like a very firm structure. And when you put the stent in there, you blow that up and you stretch it, and you put it right into that annulus so it fixes in there. So, if you were to pick it up with a string, you could hold up the whole heart with that. It doesn't pop out.
It's done without any significantly large incisions. So it's a major, major advance.
We don't take out the aortic valve, we just push it out of the way.
We have patients come to us saying, I don't want my chest cut open, and wanting this procedure is not a qualification for it, and we can't offer it to just anyone. We have to be justified in making that offer.
And there's a score that can be used. It's called the STS score or the Euro score, which evaluates risk: renal failure, lung disease, frailty indexes, previous bypass surgery. All those things go into it, and then you can kind of get a standardized score that you can think puts you where you are in that risk, and the surgeons use that plus clinical judgment.
As the boomers age, there will be more aortic stenosis, and it's likely that many more people will benefit by this procedure.